Hello, I'm Dr. John White, Chief Medical Officer at WebMD, and welcome to Coronavirus in Context. Today, we're going to talk about whether or not we're managing coronavirus correctly, and do we need to think about a change in our treatment regimens. And my guest is Dr. Cameron Kyle Sidell. He's a physician trained in emergency medicine and critical care, and he practices at Maimonides in Brooklyn, New York. Welcome, Dr. Sidell.
Thank you very much. Thank you for inviting me.
So you've been talking a lot about the number of patients, the percentage of patients actually that are dying on ventilators. When did you first notice this trend?
So in preparation of opening what was, going to be what became a full COVID positive intensive care units, we kind of scoured the data just to see what was out there. And obviously, those that have experienced it before us, primarily the Chinese and the Italians, it was hard to find exactly, what the rate of, what we call successful extubation, meaning someone was put on a ventilator and taken off. And that data is still hard to find. And I imagine there's a lot of people still on ventilators. But from the data we have available, it appears to be, somewhere between 50 and 90%. And it seems that most reports or most published data, puts it around 70%. So, that's a very, very high percentage in general when one thinks of a medical disease.
And you've been talking on social media. You say you see things that you've never seen before. What are some of those things that you're seeing?
So when I initially started treating patients, I was under the impression, as most people were, that I was going to be treating acute respiratory distress syndrome that was similar in some sense to the, ARDS that I saw as a fellow. And as I started to treat these patients, I witnessed things that are just unusual. And I'm sure doctors around the country are experiencing this. It's not, in the past, we don't see patients that are talking in full sentences and not complaining of overt shortness of breath with saturations in the high 70s. It's just not something we typically see. When we're intubating some of these patients, that is to say, when we're putting a breathing tube in, they tend to drop their saturations very quickly. And we see saturations going down to 20 to 30. And typically one would expect some kind of reflexive response from the heart rate. Which is to say, usually we see tachycardia, and if patients go too low, then we see bradycardia. And these are things that, we just weren't seeing. I've seen literally a saturation of 0 on a monitor, which is not something we ever want and something we actually actively try to avoid. And yet, we saw it, and many of my colleagues have similarly have seen, saturations of 10 and 20. And our whole practice is aimed, when we try to put breathing tubes in, is to avoid this very situation. Now, these patients tend to desaturate extremely quickly, and so these situations have occurred. And still, what we're seeing, that there was no change in the heart rate, is just unusual. It's just something that we are not used to. So that's
suggesting that this is more like a high altitude sickness. Is that right? Rather a viral pneumonia that we're talking.
Yeah. So what I was trying to find, the patients in front of me are unlike any patients I've ever seen. And I've seen, a great many number of patients, and I've treated many diseases, and you get used to seeing certain patterns, and just the patterns I was seeing did not make sense. Now this, originally came to be when we had a patient who had hit what we called our trigger to put in a breathing tube, meaning she had displayed a level of hypoxemia, of low oxygen levels, where we thought she would need a breathing tube. And most of the times when patients hit that level of hypoxemia, they are in distress and they can barely talk and they can't say complete sentences. And she could do all of those, and she did not want a breathing tube. And so she asked that we put it in at the last minute possible. And it was this perplexing clinical condition. When I was supposed to put the breathing tube in, when was the last minute possible? And all the instincts as a physician, we're looking to see if she, so-called tires out, if she's getting too tired. none of those things occurred. And it's extremely perplexing, but I came to realize that this condition is nothing I've ever seen before. And so I started to try to read and try to figure out and leaving aside the exact mechanism for how this disease is causing havoc on the body, but just trying to figure out what the clinical syndrome looked like.
You talked a little bit about the data from Italy and Gattinoni. Were you aware of what was going on in Italy before you noted these observations, or did that come after the fact?
So that came a little bit after, and I wasn't aware. I can't even remember the exact timeline, but in my reading, I sort of came upon decompression pulmonary sickness, which is, essentially the bends when divers dive and come up too quick, which seem to have some kind of a mirror picture clinically as these patients. And then, in discussions with other people, it came up that, they do similarly appear clinically. And this is not to say that the pathophysiology underlying it is similar, but clinically they look a lot more like high altitude sickness than do pneumonia. And Gattinoni, he published something on March 20th, which was about 2 days before I opened the ICU. And I don't know that I read it then, but somehow it got passed around. And in my mind, by the time I read what he was saying, I'd come under the impression that this just wasn't the usual ARDS that we were used to seeing. It was a high compliance disease, which every pulmonologist and anyone managing a ventilator can see. That's not a question. And so then when I read his stuff, where he's suggesting that the management strategy that we use is essentially somewhat flipped, at least in these high compliant patients, it just became more clear that if we operate under a paradigm whereby we are treating ARDS in these high compliant patients, we may be not operating under the right paradigm, which is
how have you changed your protocols then?
So to be honest, I've run into a great deal of resistance within my institution, which is not to say that anyone is trying to stymie progress at all. These are the protocols that are in every major hospital and minor hospital. I mean, we generally
you talked about in your videos,
yeah,
against long-standing dogma. So what's been the response from your clinical colleagues as well as hospital administrators?
So to be honest, in the ICU, I started to try to run not my own protocols, but to treat patients as I would have treated my family under with a different goals, which is to say a ventilation. However, these didn't fit the protocol, and the protocol is what the hospital runs on, what the respiratory therapists, what the nurses. I mean, everyone is part of the team. And so actually we ran into an impasse where I could not morally in a patient doctor relationship, I could not continue the current protocols, which again are the protocols of the top hospitals in the country. But I could not continue those. And obviously they couldn't have you can't have one doctor just doing their own protocol. So I actually had to step down from my position in the ICU. And so now I'm back in the ER, where we are setting up slightly different ventilation strategies, but fortunately we've been boosted by recent work by Gattinoni, which actually was formally published today, which does outline not the best evidence-based and at least expert recommendations for changes in what were our overall protocols.
Quickly, can you tell us what are some of those changes that you're going to make?
First, I'll describe sort of what Gattinoni is saying, which is that really what we're seeing in ARDS are two different phenotypes. One in which the lungs display what you call high compliance, low elastance, and one in which they have low elastance and high compliance. And so really what that is, to say simply for people who are not, pulmonologists, is that if you think of the lungs as a balloon, typically when people have ARDS or pneumonia, the balloon gets thicker. So not only do you lack oxygen, but the pressure and the work to blow up the balloon becomes more. And so one's respiratory muscles become tired as they struggle to breathe. And so patients need pressure. What Gattinoni is saying is that there's two different essentially phenotypes. One, in that sense, where the balloon is thicker, which is a low compliance disease. But in the beginning, they display high compliance, which is to say that imagine if the balloon is not actually thicker, but thinner. Mm-hmm. And really, so they suffer from a lack of oxygen, but it is not that they suffer from too much work to blow up the balloon. So, as far as how we're going to switch is we're going to take our approach differently from the traditional ARDSNet protocol, in that we are going to do an oxygen first strategy, which say we're going to leave the oxygen levels as high as possible, and we're going to try to use the lowest pressures possible to try to keep the oxygen levels high. And so that's the approach we're going to do, so long as the patients continue to display the physiology of a low elastance, high compliance disease.
Do you feel that somewhere the world made a wrong turn in treating COVID-19?
I don't know that they made it wrong. I mean, it came so fast. I think that one thing we benefit from is that the Chinese and the Italians were hit first, and they were hit hard. And I cannot imagine. I mean, really, New York is being hit so hard. It's hard to switch tracks when the train is going, a million miles an hour. And I think in that sense, we benefit from their shared experience. And I think it's important that we listen to that experience. But I do think that it starts out with knowing, or at least accepting the idea that this may be an entirely new disease. Because once you do that, then you can accept the idea that perhaps all the studies on ARDS in the 2000s and 2010s, which were large, randomized, well-performed, well-funded studies, that perhaps none of those patients in those studies had COVID-19 or something resembling it. And so it allows you to move away from a paradigm in which this disease may fit. And unfortunately, you kind of have to walk somewhat into the unknown. I think
you're advocating something a little different. So what are the consequences of you being wrong? Albeit well-intentioned. What if you're wrong?
At this point, I would say, right now we have some of the greatest experts in the world giving their opinions now. By that I mean the Italians and Dr. Gattinoni, which is suggesting this. So, I certainly could be wrong. And really, what more I'm asking for is not even an immediate change in the ventilation strategy, because I am not. I'm critical care trained. I'm not pulmonary trained, and I'm not as experienced as many around the country and many in my own hospital. But what I would like to see is all these great minds get together, and if they can accept this notion that perhaps we need to switch paradigms, and they're able to better create a path forward that fits the disease, I would gladly follow them. And so really what I'm asking and what I'm requesting is that all the experts of the field, get together and perhaps come up with some fresh recommendations.
Now, you've been active on social media, as I mentioned. Are you a whistleblower?
I don't, I've never, this is sort of my first foray into social media. I don't know that I'm a whistleblower, because I don't know that anyone was trying to purposely do any harm. I think that, all the physicians involved and all the nurses and everyone writing protocols, everyone, I believe, is working as fast and as hard as they can with utter good faith and pure intention. I think that for me, I saw something clinically that didn't make sense. And seeing that New York is about 10 days ahead of the country, I just felt compelled to get that information out.
Has speaking up impacted your professional career?
I mean, I don't know yet. I don't know. In one sense, I feel I have not felt qualms about it. I for whatever reason, I trained in critical care and I was an ER doctor, and I think part of that allowed me to see it a little bit better, because if you just receive these patients in the ICU on breathing tubes, it's very hard to see this physiology. And, I was running around the hospital from the ER to the floors to the ICU, and I saw them in all stages of this disease. And I think part of it is when you see them in all those different stages, you're able to see that something physiologically doesn't make sense. And so in a way, I do feel that somehow my training and my position, and being in New York City, allowed me to see this. And so I have not felt any conflict about coming forward per se. And I don't know what it will do for my career, but I hope that people know that I'm not doing this with any kind of, I'm not trying to stymie anything or to, it's really, I'm doing what I think is right.
What are the two things that we need to be doing right now, in your mind, to really kind of address the mortality?
Well, that's to go back to your question of if I am wrong, doctors right now, and these are my colleagues, we are desperate now in the sense that everything we are doing does not seem to be working. So we reached a point that in other diseases we have not reached, where many physicians are willing to try anything that may help, because so little seems to be helping. As far as what we can do, one of the reasons I hope to speak up, and I hope people at the bedside speak up, is that I think that there may be a disconnect between those who are seeing these patients directly, who are sensing that something is not quite right, and those brilliant people and researchers and administrators that are writing the protocols and working on finding answers. And so I think that, if the first thing to do is, if we can admit this is something new, I think it all starts from there. And I think that we have the kind of scientific technology and the human capital in this country to solve this, or at least have a very good shot at it. So that's, the first. And I think the second thing is that whatever collaboration we can do with those who came before us, and by that the Chinese and the Italians and the Egyptians and whoever else has experienced this, anything we can learn from them, I think we need to open up and be ready to receive their help.
Well, Dr. Kyle Sidell, I want to thank you for speaking up and sharing your story with us.
Oh, thank you very much. I appreciate you allowing me to speak.